Okay, so you are in live. Ma'am, can we start our today's session?
Yes, please.
Okay. Good evening and welcome to all the present in this session. I am Sneha from Clarnet. Clarnet is very proud to be a part of this webinar as a digital partner. Now I'd like to play a short video from Clarnet. Uh, Thank you so much all for your patience. Clarnet is India's largest live digital CME and doctors-generated medical content platform. Our website is www.clarnet.com. We will invite all the doctors to visit our website. Now, without further delay, I would like to take this handover this session to Nehal ma'am. Over to you, ma'am. Kindly proceed.
Thank you so much, Sneha. And for today's session, my sincere apologies for the background music. I'm outside and there are weak connections, so not even switching my video on. Sorry for that. Welcome all to eGurukul Pathshala PG Clinic. There is a case discussion on neonatology today, and we have eminent experts with us. One of them is Dr. Amar Shah, who is pediatric surgeon practicing at Ahmedabad, neonatal and pediatric surgeon, and he is pediatric endoscopic surgeon and urologist also. He is a director, Amardeep Multispeciality Children Hospital and Research Center at Alice Breach, Ahmedabad. He was Joint Secretary at Indian Association of Pediatric Surgeons in 2019 to 21 and EC member of Society of Pediatric Urology from 2016 to 18 with EC member at Pediatric Endoscopic Surgeon of India from 2020 to 2022. Welcome, sir. Another expert.
Thank you.
Another expert we today have with us, Dr. Dipen Patel. Sir is a professor of neonatology at Sri Krishna Hospital, Pramukh Swami Medical College, Baikaka University at Karamsad. He is at present President NNF Gujarat 2023. He was Secretary AOP Karamsad in 2017 to 2021 and Organizing Secretary of Guj Neocon 2016. He is faculty in various programs like NRP, Pediatric ALS and BLS, and Research Methodology Workshop. Welcome, Dipen bhai.
Thank you, ma'am.
So today we have a presenter, Dr. Augustine, and his mentor, Dr. Prashant Prabhu, sir. He is an associate professor from Department of Pediatrics from GMC, Goa. Welcome, Prashant, sir.
Yeah.
Today, we are waiting for Dr. Baldev Prajapati, sir, and he will be joining soon. So, okay, sir,
I'm here only.
Okay. So,
thank you.
Sir is professor and head at GCS Medical College, and he is the convener of this eGurukul Pathshala. We were missing him since last 2 or 3 episodes, but now he is again with us. Welcome, sir.
Thank you.
So this is a discussion on neonatology, and Augustine, all the best for you.
Thank you, ma'am.
Sir, platform is all yours.
Yes. Good evening, friends. Sorry, due to some technical issue, I'm late for a few minutes, but I think no problem. All of us know that this is the best learning session for all of us, besides students, even to the faculty also. And I missed actually exactly that who is the presenter, but I learned that from Goa Medical College, the presenter is there. May I locate name, please? Dr. Dipen, can you help me?
Sir, Dr. Augustine Edward is the presenter.
Okay, okay.
Yeah.
Uh, okay, to make it simple, I will say Dr. Edward. And you know, Edward name in our medical science also so many times we come across. So I think Edward, I think you must have been familiar with this our post-graduate presentation. First, you can share the PPT and start the history part. I think all of us will attend the history part, and whatever the points we have to say, or even some questions or some comments. I think once he finishes the history, we'll go for the history discussion, then further examination, and in that case, I think we'll develop the case. With these few points, I request Dr. Edward to share his screen and start this history part, sharing the PPT.
Okay, sir. Sir, I'll start the presentation.
Yes, yes.
Presenting the case of a 3-month-old female child, Umaima, second born of a non-consanguineous marriage, resident of Vasco, and history is given by mother, which is reliable. This is the photo of the child. And coming to the presenting complaints, the child presented with yellowish discoloration of skin from day 3 of life, till date, abdominal distension for 15 days, grayish white stools for 15 days, high colored urine for 15 days, and fever for the past 7 days. Since the complaint started from the neonatal period, I would like to elaborate the history. Antenatal. In the first trimester, mother was married at 8 months of age. This is the second pregnancy conceived spontaneously after 2 years of marriage. Blood group of the mother was O positive. Pregnancy was confirmed by urine pregnancy test at 4 months. The mother was booked and continued antenatal checkups in Chikalim Sub-District Hospital. Weight checked at the booking visit was 52 kgs. Total weight gain during the entire pregnancy was 8 kgs. Folic acid supplements were not taken in the first trimester as pregnancy was detected at 4 months but was subsequently started. There was no history of any rash, post-follicular swelling, genital ulcers or vesicles. No history of any other drug intake or native medicines. No history of any radiation exposure. Now coming to the second trimester, quickening was felt at 6 months of age. Iron, calcium, folic acid supplements were taken. 1 dose of TD injection was taken as mother was completely immunized and 2 doses were taken in the previous pregnancy. No history of any raised blood pressure, blood sugars or hypothyroidism. No history suggestive of any urinary infections. Scans done during the second trimester were said to be normal and Leica was said to be adequate. Coming to the third trimester, mother was perceiving good fetal movements. The third trimester scan was normal. No history of any itching, yellowish discoloration of eyes or abdominal pain during this time. No history of fever or pain during micturition. No history of any bleeding or leaking per vaginum or foul smelling vaginal discharge or any COVID positivity. Now coming to the natal history, baby was delivered at Asilo Hospital at term by spontaneous vaginal delivery on 30th of December 2022. Baby had cried soon after birth and no resuscitation was required. Birth weight of the baby was 2.7 kgs. And feeding was started within half an hour of delivery. Now coming to the postnatal history, baby was kept by mother's side. Baby had passed urine and stools within 24 hours of delivery. Baby was taking breastfeeds well and was active and playful. There was no history of any respiratory distress, bluish discoloration of skin or any abnormal movements. On day 3 of life, child was noted to have yellowish discoloration of skin, for which child was shifted to an ICU in view of high levels of jaundice on blood tests, according to the mother. There was no history of any scalp swelling, skin bleeds, or excessive crying, lethargy, fever, or excessive weight loss or neonatal seizures during this time. At this time, child was passing golden yellow stools and clear urine. In NICU, baby was kept under blue light according to the mother for 15 days. Baby was on full breastfeeds during the NICU stay. No history of any blood transfusions or any antibiotics or IV fluids during the NICU admissions. Baby was started, at this time, mother gives history that baby was started on multiple vitamin supplements. Baby was shifted back to the ward on day 18 of life as jaundice was told to be decreased, and baby was discharged at around 20 days of life on multiple vitamin supplements. Baby was kept under regular follow-up. Blood levels of jaundice were being serially monitored and were told to be normal, even though the child's skin was still appearing yellow. Now coming to the presenting illnesses. Child was in a usual health 15 days back when mother had noticed abdominal distension. The distension was noted to be more in the upper abdomen and was gradually increasing. It was not associated with any feeding or no history of any swelling of the lower back region or puffiness of the face. Mother also noticed change in color of the urine from yellow to grayish, color of stools from yellow to grayish white in color since the past 15 days. The child passes 2 to 3 such stools in a day, which was semi-solid in consistency. Also, mother has noticed that the urine of the baby was dark yellow in color, which was initially clear to light yellow, and also deep staining of the diapers. Also, child passes urine. So this is a photo showing the color of the stools which the child was passing for the past 15 days. The child also developed fever for the past 7 days. Fever was undocumented by the mother and was subsiding with medications. Fever was not associated with any rash and child was active during the interfebrile period. There is no history of any constipation or vomiting, no history of any of giving any alternative or herbal medicines, no history of any decreased activity or decreased feeding, no history of any excessive crying or crying during micturition, no history of any abnormal movements of limbs, and no history of bleeding from immunization sites. Coming to the developmental history, gross motor wise, partial neck folding has been achieved. In fine motor, the child grasps objects kept in the palm. Language, cooing is present from 2 months of age. And in social domain, social smile has been there from 2 months of age, and child can now recognize the mother. The developmental quotient is 100% in all fields. Now coming to the feeding history, child was on exclusive breastfeeds every 2 hourly and also on demand. Child was passing 6 to 7 times of urine 6 to 7 times a day and sleeping well in between feeds. Good weight gain was documented in the immunization visits. And now for the past 2 weeks, child was started on breastfeeds plus spoon feeds of formula feeds, 45 ml every 3 hourly with 5 drops of Simile MCT oil added to each feeds. And mother is adding 2 scoops of formula to 60 ml of water, which is adequate. In the immunization, child is partially immunized. Birth vaccines and the 6 weeks vaccines were taken. The 10 weeks immunization is pending as during that visit, child was found to be icteric during the immunization visit. Now coming to the family history, this is the pedigree chart. And there are no family history of jaundice, no family history of any gallstones, abdominal surgeries, unexplained bleeding manifestations, or early unexplained deaths. That is with my history, that is also. So,
Okay, what is your summary? Just you can describe it.
So summary, this is a term appropriate for gestational age, partially immunized child who is developmentally normal with persistent cholestasis as evidenced by jaundice from day 3 of life with abdominal distension, pale stools, high colored urine for past 15 days and also having fever for the past 7 days.
Okay, Dr. Adit, can you just stop sharing for a
Yes,
while?
sir. Yes. Video. Pause. Okay, sir, I've paused.
Can you stop sharing?
Sir, I've paused the sharing on my end, sir.
No, I think it is seen on this slide, my screen. I hope that others are also having the same, Dr. Amar.
Yeah, we can see the screen.
Yeah, so I think it's not stop sharing.
Yeah, Augustine, you stop screen share.
Stop. Okay, sir.
Stop screen
Yeah,
share.
now it's
Yeah.
Okay.
Yes. I think before we go for the discussion, because I would like to identify, Dr. Edward, you can, whether other your friends are there on the screen, other students.
Yes, sir.
Can you just identify, or I think even students themselves should give the introduction, their introduction. Who are they, please, so that you know what happens, that we can have the interactive session. Not just Edward, all others should participate, and then we can have the best learning. Not just, I will say, monologue or one person. It's not like exam. Please introduce yourself, other students.
Sir, I'm Dr. Kundan from Goa Medical College.
Okay, Dr. Kundan, you are from?
Goa Medical College.
Okay, fine. Next. Next students.
Sir, I am Dr. Sonali from Goa Medical College.
I think you should be very quick. Why? So that period. Others, yes,
I'm Dr.
Kundan, Sonali.
Viraj from Goa Medical College.
Okay, Viraj. Any other?
Good evening, sir. Dr. Chandan from Goa Medical College.
Okay, Chandan. So
Good
many
evening, sir. I'm
friends.
Dr. Nishi from Goa Medical College.
Nishi, yes. Others, I am putting your name on my paper so that I can remember and I can interact and call even personally to all of you. Anybody else now on the screen?
Sir, I'm Dr. Ifsil from Goa Medical College.
Okay, Dr. Mamba. Anybody else left?
Dr. Deepa from Goa Medical College.
Oh, I think so many students are there, then why you are silent? Anybody else?
Dr. Rahul from Goa Medical College.
Goa Medical College.
Dr. Rajat. Dr. Mamad, you should mute yourself because some. Dr. Mamad, yes, thank you. Anybody else? Anyway, I think it's a good number of the students, and my next request, please keep your video on, all the students, so that we have the feel that as if we are in the classroom and talking each other with physical presence. There we have the limitations on the online discussion, but still we can make it more of the interactive and interesting. Please hear my request to all the students. Please participate very actively in the discussion. Whatever the point comes to your mind, you should ask, you should share, even you can put your comment also. There and then we can learn. I think my question to Dr. Rajat. Dr. Rajat, on the third day, he said that third day of life, the jaundice was noticed. I hope that you are able to listen, Dr. Rajat.
Yes, sir.
Yeah, can you make a video on? I hope that you don't mind.
Yes, sir.
Yeah. Because I would like to see the faces of the student so that I can remember even. Suppose you are on the call and on the third day of life, the baby is brought to you. It is jaundice. Forget regarding all the details what Dr. Edward has provided to us. I think all the details will go later on. The baby is brought to you on the third day of life with the jaundice. How will you proceed further? What points will come to your mind? And how will you try to decide the cause for the jaundice? Please, yes.
So first we have to see if the feeding, the adequacy of feeding.
Good.
Because breastfeeding jaundice, usually when there's inadequate feeding, there's increased enterohepatic circulation.
Very good.
And it can lead to jaundice.
Yes, I think you said the breastfeeding jaundice, but another terminology breast milk jaundice. Whether both are same or different?
So no, breast milk jaundice is because of the factor beta pregnenolone, which interferes with the enterohepatic circulation.
Very good, very good. I think you are knowing so much, then why hiding yourself? Very good. Okay, so one question you will ask me regarding the feeding. Anything else further? What other points you will check?
So any sir, we have to check for if there's any septic, the septic screen for any sepsis which can lead to.
I got your point. You will keep in mind the sepsis also. Good. Further.
Say any hemolytic diseases which can the blood group of the mother, it can be Rh.
That's the point. That's the point. You should ask the blood group of the mother. Here, I think he said O positive.
So if the mother is O, then the ABO incompatibility chances are more if baby is A or B blood group, non-O blood group.
Very good. So I think ABO will keep in mind. Further. Suppose the ABO is not the issue, feeding is good, no sepsis, then what common cause for the jaundice you will keep in mind on third day of life?
So any presence of scalp swelling such as the
okay, that he had checked and it is not there.
Sir, hemolytic disease. So we have to see if the vitamin K injection was given to the baby at birth.
I think routinely it should be given and must be given.
Yes.
And I hope that here also it is given.
Yes, sir.
Right. So how that whether the vitamin K, which vitamin K should be given so that it may not create the problem of aggravation of jaundice? What are the types of vitamin K in other way? What are the types of vitamin K? What are the types?
So there are three: vitamin K1, K2 and K3.
Very good. I think you are knowing everything what I ask. I'm quite happy. I hope that you are in the final year.
So no, second year.
Oh, so you have the good time even for the preparation. And I'm sure that with the preparation you are discussing, probably you will create the problem for me because you must have come with the full preparations. Anyway, good points. What is the most common cause for the jaundice? You'll keep in mind. Suppose all these points are not there, but still jaundice is there on third day of life, third or fourth day. Then what is the most common cause? Most common cause. As you said, all the common conditions you kept in mind, you checked, nothing is there, but still jaundice is there.
So then we have to suspect hemolytic diseases, any hemolytic anemias.
Okay. There is no significant anemia.
The direct Coombs test, sir, if there's any.
Rather than giving the hint that no cause is there, no pathology, but still jaundice is there. Then what is the most common cause for the jaundice? I think Deepa wants to answer. Dr. Deepa?
It could be physiological jaundice.
Yeah, so why you should forget it? Physiological jaundice, and I am sure that on third day, if you not significant point, you will keep in mind the physiological jaundice. Right. Deepa, you will have to explain me what is the physiological jaundice and why it happens so. And if you don't mind, can you keep your video on, please? Or anybody can answer. Anybody. Please raise your hand. Dr. Chandan, very simple, basic question. Why the physiological jaundice we see in the newborns, and what is the explanation and what is the characteristic? When you will say it is physiological?
Sir, mainly increase erythrocyte turnover and decrease hepatic maturation.
Sorry, I'm not able to locate. Can you locate yourself? Introduce yourself.
I'm Kundan, sir.
Dr. Kundar. So now, please come on.
Mainly due to decrease hepatic conjugation.
Please, all other students, keep your video on. Keep your video on, please. Yes, Kundan, carry on.
Sir, it is mainly due to decrease hepatic conjugation of the bilirubin, sir. And another one is the increase RBC turnover due to the premature lysis.
Okay. Dr. Rahul, can you take it further? What are the criteria of physiological jaundice? What are the criteria of physiological jaundice?
So, physiological jaundice, sir, appears after 24 hours of life.
Okay.
And it is mostly unconjugated hyperbilirubinemia only.
Very good.
So yeah, and it should not elevate more than 2 milligrams per deciliter per day.
Okay. Can you remember at least the maximum level cutoff value where we consider physiological in term and preterm? Anyway, can you remember some days? What is the duration? Up to what time you will consider physiological? Beyond that, you may doubt that, oh, it's not physiological.
14 days, sir.
Okay, maximum 2 weeks. And here in this patient, I think maybe what Dr. Edwards said started on 5th day, but it continued. Now, do you think it is physiological or pathological jaundice in our patient? Dr. Viraj is putting 14 days and 15 milligram. Yes, but Dr. Viraj, I think you should speak. It's good even you put on the screen, but you can speak. Why I'm please insisting, our aim is not to just discuss the case or condition. We want to train ourselves. And once you speak, once you will interact, even you can speak in the exams also. Many a times what happens that you are knowing but not able to speak because we have not performed the habit. And therefore participate in the discussion. Maybe right or wrong, I think nobody is even 100% knowing, even teachers. So that is no problem. So please. Okay. So Rahul, is there any criteria for the pathological jaundice? Suppose the baby is brought to me in 12 hours with the jaundice.
Yeah.
Within 12 hours.
Then, sir, we will consider it as pathological jaundice only, because within 24 hours, whenever there is jaundice, we will consider it pathological. So that hemolysis which has already occurred in the baby. So that's the
Okay. Who will speak that? How will you examine for the jaundice in the newborn? Here we are not physically present or we don't have the baby, but at least you can describe. Rahul, can you describe that? How will you examine for the jaundice in the newborn? Somebody is going to ask in the exam that demonstrate. How will you see for the jaundice in the baby? Rahul, you are muted. You are muted. Unmute yourself. You are muted. I think unmute yourself, Dr. Rahul. Okay, I think you are not able to unmute. Dr. Rajat, can you take it? Dr. Rajat,
Yes, sir.
Please make the video on. I think I don't know why the students are making the video off. Why you are shying off? Why? Why? I think on the contrary, remain on the screen. Yes. How will you examine the newborn baby for the jaundice?
So by Kramer's rule.
How will you examine? I'm asking for the examination. Just you can narrate. I think I may ask for the demonstration if physically we are examining the baby, but here that we are not able to do, but at least you can describe. And I'm sure this is very important.
So first we assess the level of the jaundice based on Kramer's rule.
But how will you examine? Rajat, how will you see? That's my point.
So take the baby to this bright light, and
Good.
then we have to see for
Adequate
the
exposure.
presence of icterus yellowish discoloration on the forehead, on the chest, abdomen.
How will you
eyes
see?
or-
How will you see? How will you see? Just you look at or you do something.
So
Blanching by
we try to
giving
blanch,
blanching.
do like a capillary refill test kind of a thing over the surface which where we
Blanching for
want-
how much time? Blanching for how much time? Is there any time? Or just you will put the thumb or finger and take it away? Suppose I am examining, I will just put it and take it. Is it right? I think most of the times we are doing like that. That's why.
Yes, sir.
At least put for 5 seconds. Why the blanching is required, Rajat? I think in our older babies we don't blanch. Just look at the sclera and we say, oh, it's jaundice. But the blanching is required in the newborns. In newborn also you can look at the skin, as you said, Kramer's criteria. Rahul, any idea why we blanch it and then decide regarding the jaundice?
No, sir.
No idea. Okay, Rajat.
No
I
idea.
think daily we are doing. You never ask yourself that why we are doing this thing, blanching. Chinmay, I think Chinmay is from Surat. Am I right?
Yes, sir.
Okay.
Sir,
And
the
that's why I'm requesting that keep your video on so that next time I can recognize you. Yes, Chinmay, come on.
the neonate, the skin of the neonate has a rich network of capillaries, and because of that, the capillary being rich and blood flowing through it, this appearance is like flush. So we need to make sure that we are actually looking at the yellowish discoloration of skin and not it is not overpowered by the redness of the blood passing through the capillaries. So we blanch the capillaries and we look at the yellowish discoloration.
Okay, I think, I remember from Dr. Ambedkar that students should gradually learn how to answer. And that is A, B, C. A means become the very accurate. B means very brief. Its answer should be very brief. And C means, what do you mean by C? Absolutely, even I'll say crisp answer. And therefore, very simple, newborns are having the polycythemia. Therefore, the skin is pink or reddish. You are not able to appreciate the yellow color in spite of the jaundice. And therefore, even it requires the 5 seconds to press it so that the polycythemia disappears and real yellowness you can appreciate. As far as possible, it should be done over the very rightly, I think Rahul mentioned, over the bony prominences, like over the sternum, over the forehead. I think very simple question. Initially, I thought that all the postgraduates must be knowing, but gradually I'm learning that basic questions should also be confirmed. Anyway, the criteria also, I think somebody said it's all right. Now coming back to our patient, I think so many things Edwards has mentioned the negative history. But without sharing the screen, can you just tell one by one points for the negative history which you have mentioned?
Sir, in the initial period, even there was no history of any scalp swellings. There was no history of any bleeding manifestations. There were no history of any petechial bruising. There was no history of any lethargy, poor feeding during this period. At that time, initially when
I think in the negative history you mentioned there is no history of fever or rashes. Even what is the importance of fever and rash?
Sir, sepsis could be one cause of pathological jaundice. So fever can be there in that case, and also in patients with dehydration also.
Even you mentioned petechial spot bleeding manifestations for what purpose? What is the importance?
Petechial lesions can be because of any liver injury. Because
what is possible in a case of jaundice in newborn, and you are asking for the petechial spots? What is the relevance? Yes, Sonali. Sonali, yes.
So the torch group of infections.
Sorry, there is some disturbances.
Sir, the torch group of infections.
Yeah, torch group of the infections, they can present with the jaundice, thrombocytopenia, petechial spots. So I think that's why. But I noted even one point Edward has asked, no history of itching or jaundice in the mother at the time of pregnancy. What he wants to convey? Anybody?
Sir, intrahepatic cholestasis of pregnancy can.
I think Edward, you must have come with the preparations. Your turn will be the last, and I'm sure that that question also will have to answer. Anybody? Sonali. He asked the history of itching and jaundice in the mother during the pregnancy. I will say how it is relevant. Usually I never ask the history to the mother during pregnancy when the baby is brought to me with the jaundice. But I think here he has done some intelligent work. So who will answer? Intelligent person can answer. And then who is intelligent? Should raise the hand. Yes, Rajat. Chinmay, any idea? Why she has included the maternal point?
Chindan has answered on chat.
Okay.
Chindan.
Okay, autoimmune, is it right? Or something else? Anybody? In other way, which type of the neonatal jaundice, particularly when you are talking of the neonatal cholestasis, where your mother can have this itching and jaundice. Anyway, we'll keep this answer at the last with the discussion with all the faculty. And Edward must have come with the preparations, full preparations. Okay, he has asked for the gallstone in the family. He has asked for the surgery in the family. What is the importance? Sonali?
The hemolytic diseases like hereditary spherocytosis,
yes,
sickle cell disease.
Very good. So at least to rule out the particularly the hereditary spherocytosis, where you know that the commonly, what type of the inheritance hereditary spherocytosis, Sonali?
Dominant. Dominant.
Autosomal dominant. And therefore the multiple family members might have been involved. Somebody might have developed the gallstone. Somebody have underwent even the cholecystectomy due to this gallstone or jaundice or something. So I think to rule out all the reasons. So I think most of the points he has done. Now coming to the point, what is the likely type of the jaundice, Rajat, in this case, direct or indirect?
So most likely it is pathological jaundice, but
yeah, that's very certain. That I think we are, once it is, remember, beyond 14 days, any jaundice, direct or indirect, always it requires a workup. And I think time duration he has given pretty long. So regarding pathological jaundice, we don't have the doubt. Now to my next question, there are two types of the hyperbilirubinemia in the newborns, direct and indirect. Here what is likely from the history, still we don't know the investigations or examination, but from the history, what is likely? Is it indirect or direct?
So most likely it is suggestive of indirect.
Okay, why?
The direct hyperbial, then there would be clay colored stools.
Yeah, but I think he showed the picture. What is the color of the stool in this patient? Sonali, have you seen the picture? The stool color which he tried to show. What is your interpretation?
So it was colorless actually.
Yeah, that means acolic.
Yes, sir. It means
Right.
it indicates a direct component, direct
Yeah.
nature.
Why? What are the points which you mentioned from which you can say that it is the direct hyperbilirubinemia? Please, one is the acolic jaundice, sorry, acolic stool. Anything else?
So the abdominal distension with abdominal distension and the healthy child who is gaining weight.
Okay. So
The
please
yellow
remember.
staining of diaper, sir.
Sorry. Yes,
Yellow
Kundar.
staining of diaper, urine color.
Yes. That is very important point. So please note the 3 points. One is the presence of jaundice. Already noted. Now I want to differentiate whether direct or indirect. Then 2 points are very important. For direct, diaper or color of the urine. Suppose if you have collected in the bottle, it will be very dark yellow. And please remember how to differentiate. Suppose jaundice is there and yellow urine, that means simply even in older children also it is jaundice. Jaundice is there, but urine color is normal. That means it is hemolysis. Jaundice is there, dark yellow urine, acolic or the white stool, and with that by chance if you get even the scratch marks or itching, that is very characteristic of cholestatic jaundice. So I think from the history simply you can differentiate that what is the likely even the problem, whether it is the hepatocyte problem or whether it is the biliary problem. I think from this history now if you have seen, which has shown very distinctly clearly that jaundice is there, dark urine is there, and white color or the clay color stool is there. Now Rajat, what is your interpretation? Already we have discussed. What is your interpretation?
So, so most likely it is neonatal cholestasis.
I will say the exam also. Never say the most likely. Why likely? I think here I am confident because you don't have the any other point to say so distinctly. Jaundice is there, clay color stool. Sometimes I think the clarity is not there. You may say probably mostly yes, but I think here it's very clear. The point is why I'm coming to the point because once you decide, I think then it is not indirect hyperbilirubinemia. Number one. So all the reasons for indirect has gone. Right? RH incompatibility, ABO incompatibility, hereditary spherocytosis, G6PD deficiency, probably sepsis, right? All the reasons are not probably coming in the picture. Here direct type, then again direct type can also due to 2 reasons, either the hepatocyte problem or bile canaliculi, biliary tract problem. Always anatomy should be decided in any discussion, any case. So that would give the idea. I think here from the history, we are clear that probably it should be the problem of hepatobiliary problem, right? And then you can focus from the hepatobiliary problem, but further you can go further. And most of the points he has tried to roll out regarding even the congenital infections, right? He has ruled out even some other infections. He has ruled out even the sepsis. I think one more point you should ask, Edward. I'm not sure whether did you mention, was there any history of delayed passage of the meconium?
No, sir. Baby had passed urinary stools within 24 hours of life.
Okay. Suppose why I'm asking this question. What is the importance? Let Sonali answer. Because why I'm asking the Edward last, Edward must have come with full preparations.
So because of the delayed passage of the stools, the enterohepatic circulation will be more.
What can
There
be
is
the
a-
reason, Sonali? Sonali, which conditions may present with the delayed passage of meconium?
So the
Hypothyroidism.
Hypothyroidism.
Very good. Hypothyroidism.
Imperforate anus.
In imperforate anus, there is no passage of the stool at all, Sonali.
Okay, yeah, yes.
I'm asking, passage is there, but it's late.
Yes, sir.
Biliary tract obstruction.
Sorry?
Biliary tract obstruction.
disease.
Let me give the hints to you. One is the endocrine cause that already mentioned, hypothyroidism. Another is the surgical condition for what Dr. Amar is waiting. Hirschsprung disease. And third, even is some immunological problem, which we are not considering, but now it is coming up and we do see whether the cases. Yes, Sonali said something.
Cystic fibrosis.
Cystic fibrosis. And whether they can have this type of the cholestasis, any condition among all these three which we consider, whether they can present as a cholestasis.
Cystic fibrosis.
Cystic fibrosis.
Very good. Cystic fibrosis can present. Even hypothyroidism is known. That can also present the cholestasis. So I think delayed passage of meconium is important from this point of view. You know, all these points, questions people are going to ask in the exam. Yes, Dr. Amar has put a very good comment, Hirschsprung disease, and even bowel atresia can present with icterus. Yes. So these are the things which we can keep in mind. Now coming to our case, before that, let me take the comments from the experts. I understand that, sorry expert, you have to wait. But you know, I am the basic pediatrician and I want to see that the students should learn first the basics. And once they are clear from the basics, then probably we can learn from you the expert things. First, I think Dr. Dipen, your points or comments on this, and then we'll go to Dr. Amar, please. Only from the history, examination is pending.
Dr. Rajat said we use Kramer criteria for assessment of jaundice. So this baby had jaundice at 3 days of life, right? So how will you assess Kramer? Yes, Dr. Edward, you can answer.
I think there are some background noises. So those who are not speaking, please keep yourself muted so that we can avoid. Please, thank you. Dr. Edward, now you can answer, please.
Sir, in Kramer's assessment, you have to see at what level of the body the baby is appearing icteric. So initially, the icterus will be only up to the face and neck, and then it will involve the if it is more than 5 milligrams, it involves the upper chest. Then it involves the that is up to from 5 to 8 milligrams. Then from 8 to 12, it would involve the upper limbs and the thigh, and more than 15, it would involve the staining of the palms and soles also.
Right. So good. So when it is up to palms and soles, is it considered something important for us?
Yes, sir. It is always pathological if it involves the palms and soles.
Right. So what are the limitations of this Kramer's examination?
Sir, one thing, it would be subjective, so it would vary depending on who is examining the child, and also it will be different in terms and preterms also, depending on the because of the skin thickness, that also can vary.
Yes. So it has very
and also complexion of the baby can also affect the observation of icterus.
So even we have experienced that one consultant will say that it is highly significant, and other consultant will also say, no, it will be very low if you send investigation. So by chance, when we send investigation, it might be very high. So it has difficult predictability. But do we have any other non-invasive test to assess bilirubin?
Yes, sir. Transcutaneous bilirubinometer can be used also.
Good. Good. So, do you have any experience of using transcutaneous bilirubinometer?
Yes, sir. We have routinely use a transcutaneous bilirubinometer in our postnatal wards.
Right. How is the accuracy of it?
Sir, plus or minus 2 values it comes between, sir.
So that's good accuracy, right?
Yes, sir.
But when it is considered significant?
Based,
Yes.
there are charts based on the transcutaneous bilirubinometer also, sir. So if
I think
more than 20, sir.
More than 15, when it shows, then always it has to be investigated.
Investigate. Yes.
So,
Dr. Rajat, I think mute yourself. Some background noises are coming. Dr. Rajat, from your side or some other place, please. Thank you. Please carry on. Sorry. Dr. Dipen, anything? Dr. Dipen, you are muted. Unmute yourself.
Yeah, assessment of jaundice is very important because though clinical relevance is less, but clinical judgment up to what level bilirubin skin pigmentation of yellow is there, we should be very cautious. Now, regarding antenatal history, we said, do we have something specific in first trimester examination, like mother has fever, rashes? Is this important for us?
Yes, sir. The intrauterine infections is an important cause of pathological jaundice. So that becomes important.
Right. Regarding differential diagnosis, yes, we have reached to a differential diagnosis of direct jaundice. Does second trimester ultrasonography has any role to pick up some causes of direct jaundice?
Any cysts which are there can be picked up from the biliary tract, like choledochal cyst.
Very good. Yes. What else? Extra information can we have?
Then any other congenital anomalies, also like Down syndrome, anything which can be associated with hyperbilirubinemia can also be picked up during the anomaly scans also.
Right. Something specific to liver, gallbladder, like absent
biliary atresia.
Biliary atresia. Okay. Maybe
Allergical syndrome, like paucity of bile ducts.
But will you be able to see in sonography?
No, sir.
Right. So I think absent gallbladder, intrahepatic cyst, they might be important feature for us to further look at the cause.
Yes, sir.
So first trimester sonography, right? You already said that other anomalies. Which are the other anomalies which specifically will have in certain liver disorders, other congenital anomalies, other system anomalies?
Cardiac anomalies.
Like?
Sir?
Like?
In allergical syndrome, there will be pulmonary stenosis, can be peripheral pulmonary stenosis can be there. Then in Down syndrome, endocardial cushion defects can be there. Zellweger's also could have, sir.
Right. So pulmonary stenosis or pulmonary atresia, sometimes pallid statology, VSD, if they are there and you have absent gallbladder, it might be saying something. Sometimes there are other features like situs inversus. We may point out midline liver, especially in antenatal sonography, polysplenia, absence of spleen. These may also say that there might be some associated liver disorder in this case. So we have to be very much cautious with this kind of history.
Yes, sir.
So now you said phototherapy was required for 15 days. So I wonder, rarely needed in my experience. So can you say why 15 days phototherapy? Was it intermittent phototherapy, stopped, and then baby appeared, jaundice again started? Rarely it is required actually. Unless it is a kind of, which kind of unconjugated hyperbilirubinemia will require prolonged phototherapy?
Hemolytic jaundice, if it is there.
Okay.
So I think Dr. Dipen has taken the very good question.
Right.
that here even the phototherapy may require in the older children. The child has become now infant, but still phototherapy. And many a times we advise to purchase them the phototherapy at home. We can continue the phototherapy at home. Till probably they decide for further very specific treatment like liver transplantation. Which condition?
Unconjugated, definitely, right?
Yeah, and it is going to the unconjugated. So I think sufficient need. Unconjugated hyperbarythemia. It is some syndrome.
Non-hemolytic, right, sir? Maybe.
Yeah. And it requires even the only, we continue the phototherapy till you go for specific treatment.
Crickler Najar.
Gilbert.
Yes. Crickler Najar, which type even?
Type 1. Type 1.
Type 2.
Now you can decide 1 and 2 because house is divided in 2.
Type 1.
Okay. Dr. Nipen, you can take it further, please. Sorry for interruption.
So Kriegler Naser, as rightly mentioned, will require prolonged phototherapy. But here now we have turned out the case to be a direct jaundice. It might be Kriegler Naser initially or something, but unlikely then when baby does not require phototherapy after then unlikely to be a kind of indirect disease.
I think here I think I will have to mention what Dr. Nipen has raised, actually very good point which I noted but missed while discussion, that why the baby required this 14 days phototherapy, and that too, whether was it they were knowing direct or indirect fraction properly or not. I don't think that it may be the only indirect for pretty a long time. I think that will come this direct indirect interpretation with these investigations, but I think here it becomes a very strong doubt or regarding some probably improper interpretation or something is wrong, but it's very certain that it's not the common story.
So this baby was healthy, like not sick.
Yes, sir.
It would probably rule out certain disorders which causes direct jaundice.
Yes,
so
sir.
can you find out which causes will have acute sickness in a neonatal period which has cholestasis?
Yes, sir. The sepsis, in sepsis, the child would be sick. Then most intrauterine infections, the child would be sick. Then metabolic causes like galactosemia, tyrosinemia, the baby would be sick. Then in a gestational alloimmune liver disease also could be ruled out. Then
yes, I think these are the disorders.
Fine.
Yes, sir. Please take the call.
Dr. Edward, I think when you were discussing that the jaundice were progressive indirect variety which we are discussing is having the cephalocaudal distribution.
Yes, sir.
Why it is so? Why are you able to appreciate first over the face, then chest, and last over the palms and soles? Why it happens so?
The thickness of the subcutaneous tissue varies.
Yeah, that's good. You know, it depends particularly this thickness of the skin tissues, and therefore it be when many times. But you know, is it so that neutral jaundice becomes difficult to appreciate in dark rays?
Yes.
Yes, sir.
Dr. Sumant is nodding the head.
No, sir. They say in the newborn, this is just not that pigmented. Even in
absolutely. Therefore, purposefully, I asked the question. They say that not even the Asian, but even the African babies in the newborns, probably you should not face the problem due to this dark rays, right? And that's why I think it's a good boon. Otherwise, it may be the good major obstacle in our clinical assessment. I think here one point I wanted to state. You know, most of the times a person like me, always I insist that go for the clinical. But regarding jaundice, I will say, neutral jaundice, I will say, don't rely upon your clinical. Go for the bilirubin estimation. And I think Dr. Dipen touched that part. That from this even Kramer and even the transcutaneous bilirubinometer and other points, your assessment of the jaundice will give you the idea but not accuracy. And for accuracy, you should go for bilirubin estimation. Many a times it may happen so, any clinician, I think all of must have experience. I feel it's mild, probably no problem, and the bilirubin becomes quite a high. And it may cause the damage to the baby. And in medical science, particularly in pediatrics I'm talking, there are certain conditions that don't rely, most of the times I'm discussing that rely upon your clinical things. But some points don't rely upon your clinical things. Go for the investigations. One of them is a serum bilirubin, or I would say estimation of jaundice in the newborn. Another thing, similarly, even the meningitis in infants and newborns, that you cannot rely. If you have the doubt, go for confirmation by the CSF examination only. So there are certain things that wait the confirmation. I think here is one of them. I think we discussed so many reasons, but Dr. Amar is listening to us silently, that why they are not coming to the surgical conditions. I think before we go, anybody, Dr. Rajat, which surgical condition may come with the cholestasis, and directly that patient should be submitted to Amar for the surgery?
Sir, biliary atresia and choledochal cyst.
Yeah, I think biliary atresia may take some time for the workup, but choledochal cyst straight away, because you are very clear. I think Dr. Amar, you can take it, please. Surgical and other points also.
Yeah, I wanted to ask one question, is that when the child with jaundice comes to you, let's say the child comes with three females, one of which is the mother and the two are the aunts. Okay, the question that you first ask when you see a jaundice child is, what is the color of stools? Now, it may not be always possible that the mother may bring a picture or something like that for you as a reference point. So what would be the different ways in which you can identify what is the exact color of stool? Because sometimes the mother said that the child is passing yellow stools. The aunt would be saying that the child is passing white stools. So what would be your reference point, or how would you yourself make a perfect diagnosis as regards the color of the stool? Because it is very important as to where the child would then land up. So what are the different options that are available with you? Clinical options.
The stool color cards are there, which you can use to.
Stool color card may not be available everywhere. I mean, not in district places. Stool color card is correct, but still it may not be available everywhere.
I think what Dr. Amar wants to know, that suppose child is brought to you, even you have got the stool sample, how you will decide?
Suppose you have not got a stool sample. Suppose you have not got a stool sample or even a photograph of the color of the stool.
Yeah.
How would you determine what is the color of the stool? Because your identification and documentation as a pediatrician would be very important, because it is the documentation by a pediatrician of the color of the stool which has a great value and weightage. So what would be your clinical protocol or clinical? Because this is a practical problem that we face every now and then in OPD.
And I think that is why many times the baby is submitted late to the surgeon, because probably we don't go for all the things and don't decide that it is a direct type or atresia or something. Or that decision, it takes pretty a long time, and therefore I think Dr. Amar wants to know that being the general pediatrician, you decide these things. Anybody?
Do you have any reference
Dr.
point
Amar,
other
you will
than
have
the
to
stool
take.
color card? Any other reference point?
Compared to the diaper, you can also.
The child does not. I mean, the child does not pass stool in the diaper. The mother says the stool color is light yellow. Now, how can you determine what is light yellow? There are two options. I mean, see, there are two options. You can either show them physically a color which is there in the hospital or anywhere, even on your mobile phone, you can show them a color which can act as a reference point. And the second and the most important thing for you to do is to do a per rectal examination with a little finger. It may be slightly traumatic for a neonate, I agree, but still in this case, documentation of acolic stools is most important, because that will be a clinching factor for many a diagnosis. So
Yes, sir.
in these cases, I mean, venturing to do a per rectal examination and then slight stool will come out and you will be able to see with your own eyes as to what the color of the stool is.
Yes, sir.
Okay. So that is all I wanted to say for the clinical examination.
Okay.
I think here Dr. Amar has reminded me the very good point, and Dr. Edwards also you touch it. Let me ask the other students. Dr. Kundan or Rajat, can you make a video on? Dr. Rajat, okay, Dr. Kundan, good. Dr. Kundan, they were talking regarding some stool color chart. What is it? Have you heard it?
At the time of discharge, we have chart. It contains the
I think you can use your mic properly so that we can listen to you, please.
sir.
Okay, or Dr. Rajat, you can take it. Probably Kundan is sitting in the some ICU or so. Some gadgets are going on. Okay, Rajat, any idea regarding the stool color chart?
Sir, this technique was mainly used in the Japanese for the screening for biliary atresia, where prior to discharge, based on the stool color, they have the varying grades are of the various grade, and that above that cutoff, they screen for atresia in a newborn.
Okay. You know, nowadays I would like to insist that this is not the something is new and very important. I am trying to show. I hope that you are able to see this photograph. This is the stool color chart, which recently I have included in my book, Signs and Symptoms in Pediatrics. And probably hardly it is seen, and that's why I purposefully added. And nowadays, I think all of us should know, all of us should use it. And it is available even simple in your, I will say, mobile. So even at any district place, any small place, now the mobile has reached. The reason is, you know, actually this was used in the Taiwan long back. And these, they actually, you know, must be knowing that biliary atresia, somehow I don't know, I think Dr. Amar can take it later on. They had the very high incidence of biliary atresia. And then they were searching what Dr. Amar was insisting, that earliest as a pediatrician, because you know babies are going to come to us, decide earliest that it is the cholestasis. Try to define the cause, that really it is biliary atresia, because within 60 days or earlier time we should submit for the surgery for the good results. And having this point even in their mind, the high incidence of biliary atresia in Taiwan, they devised this stool color chart. And they used to give to the mothers at the time of discharge. And even they are advising or explaining them that you see the color of the stool of the baby and try to compare with this chart. And whenever, suppose if you feel that it is of light color, clay color or white color, please come back. And by that simple methodology, they got the baby earlier, they diagnosed, and the incidence significantly they could bring down. So this happened, and sensitivity and specificity of this stool color chart is good. I think around 80-90%. So I think it's a very good chart. So I think gradually even we can also practice, and definitely it is quite useful. Rest of the things, you know, that sometimes even this even biliary atresia also may not be the clay color, white color what Dr. Edwards has shown. Even from the mucosa, shading of the mucosa, you may get even this slight yellowish or so, and very easily we can pass as a normal stool. And many times the people used to say that if you cut it, even the core will show the white stool. That also may be the important when you are actually want to assess. Here the point is what Dr. Amar is that by any means try to decide the color of the stool. I think this is the important message what he wanted to discuss. I'm sure that we have included so many things. We are only at the history at present. We are not got beyond the history. But I'm sure that is the beauty of the medicine. From the history, we can discuss so many points. So simply for the exam going students, you know, at the nowadays MD or DNB, In all the exams, they are going to ask you that a summary at the end of history, then examination, and at final. So who will give this summary? Don't repeat this all the points which we have discussed. Your interpretation, your inference, or hypothesis that what is the likely problem with the baby. Who will give the summary in about 8 to 10 lines? Edward will be the last person. Rajat, can you make the attempt?
Sir, this is a 3-month baby who has come with history of noticing yellowish discoloration for last 15 days with abdominal distension. And along with that, there's history of passing dark yellow urine and clay color stool. And most likely, otherwise antenatal birth history is not significant. And so the diagnosis most likely is suggestive of direct hyperbilirubinemia, neonatal cholestasis.
Good. I think good attempt. Anybody else would like to make one more attempt? At least average daily I asked the 2 students to make the attempt so that you can have the good exercise. And even perform this habit in your round also. I think for 2 things you should perform the habit in your round. Number 1, for this type of summary, and second, very important, nowadays your NMC is also paying the more attention and asking even the examiners for the counseling. I think at the end of this case also we should go for counseling. So for the summary, I think simply summary, very rightly Rajat has said, the 3 months female presented with apparently jaundice. We started on 3rd day of life, which required this phototherapy pretty a long time, which was not much details, but at the end probably it becomes clear that it should be the direct hyperbilirubinemia with the dark urine, white stool. It becomes very clear that it's a case of the neonatal cholestasis. With looking at the baby and rest of the other points of the sick baby or other manifestations are absent, probably neonatal infection, sepsis is less possible. And then likely some hepatobiliary obstruction is possible. If we keep in mind probably the biliary atresia, choledochal cyst or some other obstructive variety is more likely. I think you can keep it mainly simply this hypothesis which can be changed even with the examination. Should we go for the examination? Because I will have to look at the time also. So Edward, can you share your PPT and go for the examination?
Okay, sir. Sir, is it visible?
Yes, yes.
Okay. Now coming to the examination. First, the vital signs. At the time of examination, temperature was 98.8 degree Fahrenheit. Heart rate was 130 beats per minute, regular in rhythm, normal volume, character, and all peripheral pulses were well felt. BP was 84 by 50 millimeters of mercury in the right upper arm in the supine position. Respiratory rate was 38 breaths per minute and abdominothoracic type. The dextrose at that time was 92 milligram per deciliter. Now coming to the anthropometry, weight was 3.6 kg, which was less than minus 3 standard deviations for the age. Weight gain since birth was 10 grams per day. Length was 54 centimeter, which was between minus 2 and minus 3 standard deviations. Head circumference was 34.5 centimeters, which was less than minus 3 standard deviations for age. And weight for length was minus 2 to minus 3 standard deviations. Now coming to the head to foot examination, the head appears normal in size and shape. Hair was black and normal in color. The anterior fontanelle was 1 × 1 centimeters at level, non-bulging, non-tense, and no sutural separations were there. The posterior fontanelle was closed. There were no facial dysmorphisms. Eyes, no pallor. Icterus was present. No cataract. No subconjunctival hemorrhage. No bitoid spots were there. Ears, there were no low set ears. Oral cavity was normal, no stomatitis, no cheilitis, and there was no dentition in this baby. The chest appears normal in shape and size. The abdomen appeared distended. Limbs, there were no pedal edema, and there was no presacral edema also. In the skin, icterus was present. There were no petechia or rash. There were no scratch marks. No neurocutaneous markers were also identified. And there was normal female external genitalia. Now coming to the systemic examination. For abdominal examination, on inspection, the abdomen appears distended. All quadrants appear to move with respiration. The umbilicus appears pushed down. There was no erythema or umbilical discharge. Umbilicus was flush with the skin. There were no visible masses or dilated veins. No scars, sinuses, or visible peristalsis, and hernial orifices were normal. Now coming to the palpation of the abdomen, superficial palpation, the abdomen was soft, non-tender, there was no guarding or rigidity. Now coming to deep palpation, the liver was palpable in the right hypochondrium, 7 centimeters below the right costal margin in the midclavicular line. Liver was firm in consistency, smooth, and with rounded margins. The spleen was palpable in the left hypochondrium, 4.5 centimeters below the left costal margin in the midclavicular line, enlarging towards the umbilicus, firm in consistency and smooth surface. So this is a picture showing the marked liver and spleen in the baby. Coming to the percussion, a tympanic note was heard all over the abdomen except in the areas of the liver and spleen enlargement. Auscultation, bowel sounds were heard normally. There was no added bruit heard. Normal female external genitalia was seen, and hernial orifices appeared normal. Now coming to the other systemic examination, in cardiovascular system, first and second heart sounds were heard and normal. There were no murmurs. In the respiratory system, breath sounds were bilaterally equal and good. Normal vesicular breath sounds were heard, no adventitious sounds. In central nervous system, the child was active, alert, tone was normal, reflexes were present, power was greater than 3/5 in all groups of muscles, and there were no abnormal movements noted. Coming to the developmental assessment, the 360-degree flip, pull to sit, there was partial head lag present. During vertical suspension, there was no slipping or scissoring. In ventral suspension, head was level with the body and occasionally lifting above the level, and the lower limbs were extended. In prone position, head was in the midline, and the child tries to lift the head above the level also. Hearing, the child startles to loud sounds, and vision looks in all. The child is able to look in all directions and follow objects also. So that is with my examination.
Okay. Can you stop sharing?
Yes, sir. Yes.
I think first other students, any question, query for Dr. Edward, which you want to ask him for any confirmation, or any part is missing in the examination. Suppose if you have noted, Dr. Rajat, Chandan, anybody?
The liver span, did we? I missed it.
Yeah.
Okay.
Dr. Rajat is asking. Dr. Edward? He says that liver span you have not mentioned.
Okay.
Okay, and you know liver span is more important. By palpation, you will decide the size of the liver below the right costal margin,
Yes,
but upper border by percussion. Okay, so that's point. Anything else? Good point. Okay. Dr. Viraj, I think she has not participated. He or she, Viraj Desai. What is your interpretation regarding, I think in the vitals, anything is missing? Edward? If you are able to recollect.
Pulse oximetry can be a help.
Yeah, yes, SpO2 level. Is it important in the newborn?
Yes, sir.
What is the importance of level of the SpO2 in every newborn before discharge? What is the importance?
Sir, congenital heart diseases can be picked up early if all babies are screened at birth or just before discharge with pulse oximetry.
How will you interpret the oxygen saturation in the newborns? That means when will you consider this is something abnormal, unusual, and what is it, I would say, what does it indicate? You know, a minimum at what places you will get take the SpO2 level.
All four limbs.
Commonly, you know, in the older babies, what we do at whatever the place, one place you have noted, you mentioned that okay, 97, 98. Is the same method in the newborns?
No, sir. All four limb saturation has to be checked. Newborns.
Is it possible that different SpO2 level you may get it?
Yes, sir.
Which conditions?
Like coarctation of aorta, differential saturations can be there.
Why the coarctation of aorta you will get the different saturation? Chinmay, you have put it. What is your idea? Chinmay, unmute yourself.
Sir, could you please repeat the question?
Regarding the SpO2 level, is it sufficient in newborn to take at only one site, or you should go for multiple sites? And what is the reason?
Sir, the SpO2 should be taken in the right upper arm and one of the two lower limbs. Right upper arm being what is called the pre-ductal side, and one of the post-ductal side as well. To look at the differential in SpO2.
I think, you know, that is coarctation of aorta for detection. You go for the femoral pulsations or blood pressure measurement in all the four limbs. Right. And that difference you are going to get it, the coarctation of aorta and the blood pressure. You know, SpO2 also, you know, the differential cyanosis, that can be there. And not to miss it, it should be. Anyway, another point, is there any ascites, Dr. Edward?
No, sir. Tympanic note was heard in all areas except the areas of liver dullness and the splenic dullness, sir.
I think he has shown the picture. Simply from the picture, can you say that there is no ascites? Anybody? Dr. Kundan? Or anybody? Rajat? Please. From the picture which he has shown, can you say or make the comment regarding the presence or absence of ascites?
Sir, flanks were not appeared fully.
Yeah, good point.
Flank fullness and umbilicus would be slit shaped, so if there was ascites and.
Okay, 2-3 points you can note it. You know, please remember simply in the ascites, the collection of fluid starts from periphery. So first flanks are full and then the distension will develop in this way. Right. The first it starts from periphery and then central. And here the flanks are not that full. While in a case of organomegaly, what happens? That it develops from this central and then goes to the periphery. And I think here this type of distension is there. So it indicates at least some mass, some organomegaly or something like that. And very important that upper part, because you know umbilicus is pushed downwards. And even umbilicus is not transversely stretched. So even from simply observation, you can say, if at all, there is no significant ascites. Right. So that's a point which you can make it. Another point is, you mentioned the scratch mark, 3-month-old child, you expect that the child can scratch it, even in spite of the problem?
No, so that may not be positive in a 3-month-old baby.
Then suppose the problem is there, itching is there, how baby will present?
Excessive crying, irritability. Yes.
Yeah. On the contrary, mother will say excessive crying, and mother is trying to at least do some this smooth, I will say, over the skin. Baby feels better, right? Get some comfort, get some relief.
Yes.
I think that of the story may help to interpret whether the itching is there or not. But scratch mark we don't expect in 3-month-old child. Older babies, yes. So I think you should keep all these points. AF is 1 centimeter by 1 centimeter, 3-month-old child. Is it normal?
It's on the smaller side, sir.
So then what does it indicate? And what is the head size?
Head size also in this baby is less, sir. It comes less than -3 standard.
So size is small of the head. AF is also small in size. What is your interpretation?
It can be positive in either some chromosomal anomalies or also in intrauterine infections also can be.
I think simply whatever it is we don't know, but brain is not growing properly.
Yes, sir.
Right.
Yes.
Because size of the head is also small, because and therefore AF is gradually closing earlier.
Yes, sir.
Reason is there is no stimulus because brain is not probably growing, and even size is also small.
Yes,
therefore probably we can make the comment that likely whatever the condition, but brain growth is involved. Now, I think simple points, but we'll have to try to derive from these observations, and ultimately it contributes to your thought process.
Yes.
What is your interpretation regarding this anthropometry as a whole?
Sir, the baby has gained.
Edward, I want only one word interpretation. Only one word. That's all. Absolutely agree. We can say here it is a failure to thrive, even with macrocephaly. We can make the comment. Okay. So I think these are the points which you have made on the clinical examination. And very good that you have mentioned other things, that probably there is no any nutritional deficiencies, at least at present manifested in the form of the vitamin A or vitamin D or other things. Therefore, you can consider, or either due to the supplementation, probably there is no manifestation.
Yes.
Anything on examination? Otherwise, we'll go for this interpretation. Anything from your side, Dr. Dipe, Amar? Any points for examination, probably? Okay.
No, so I think now for signs of other liver disease phenomenon, like can we have other advanced? What are the possibilities that child is going in advanced liver disease?
Sir, if there are features of any portal hypertension, like dilated veins on the abdomen, any bleeding like hematemesis, then any bleeds brain in the brain, like seizures.
Ascites, right?
Ascites, yes.
Already mentioned.
Yeah. Irritability. I think that would probably say that child is going advanced liver disease.
Yes.
Okay. Edward, you have missed even one point to make the comment on face also. What you would like to make it? In such case.
Dysmorphic facies.
Yeah, you should say no dose dysmorphism. And if it is, you can mention.
Yes.
Because is there any importance of dysmorphism and the neonatal cholestasis?
Yes, sir.
Rajat, let others answer. I should see that others are not sleeping or running away. Dr. Kundan, please come on. I will have to mark the presence intermittently.
Down syndrome.
So usually
Alagili syndrome.
Yeah, very good. And somebody mentioned the Down syndrome. Down syndrome also can present even this way. So for Down syndrome, then what surgical condition is commonly may be there with even the neonatal cholestasis? Okay. So now I think
disease.
So I think now we have interpreted or confirmed these physical findings. Anybody can make it summary of the positive finding, just summary of the positive finding, because that will give us some clear picture that what is the problem with the baby. Just positive findings. Perform this habit, because even as a clinician also, after examination, if I just note it, that what are the problems with the baby, what are the positive findings which I got on examination, and which are even the absent, and that will give you the idea that what is the likely picture with the patient. That's why I'm asking you. Anybody? But I wish that the students should participate in the discussion. Dr. Chandan, you can take it. Would you like to take? I think you are very patiently listening to all of us.
A 3-month-old baby who was appropriate for gestational age at birth, but now we're presenting with failure to thrive, with the general examination showing the stable vitals with ICTRIS, on specific systemic examination showing the hepatomegaly, with no other signs of bleeding or petechiae, or no other dysmorphism suggestive of syndrome.
Very good. I think you mentioned the good points. Very good. The only thing, always try to put in an order, sequence. But you have put it, I will say, good points. You have noted it. Very nice. You can say simply that 3-month-old child with what we are thinking of neonatal cholestasis. On examination, we found that vitals are normal, but child is having the failure to thrive, small head, and even with this icterus is noted, hepatosplenomegaly, no any bleeding tendency or any skin bleeding marks, no ascites, and others even with the no dysmorphic facial features or other abnormal findings on other systemic examination. So we have the positive points, and even I will say, you can say that not sick looking baby. Right. I hope that Edward, is it right? Not sick looking baby? Or
The
sick
baby
looking,
was active and alert, sir.
yeah, so not sick looking. Now, having these findings with the history already we have discussed, what conditions are coming to your mind? What things you will consider? Come on. I think now if I ask the question which we have kept pending, we ask something in the antenatal history that mother had no itching or even the jaundice during pregnancy. What is its importance with this presentation?
Intrahepatic cholestasis.
Okay.
Neonatal alveolar disease.
One of the varieties of neonatal cholestasis, that it familiar persistent intrahepatic cholestasis. And that can be even in the, pedigree also is prepared very nicely. Always in such cases, prepare the pedigree for 3 generations and make the point clear that in any generation, whether any person was affected and in what way. I think here he has made the clear. And even sometimes mother can also have the history of even the itching simply or mild jaundice or some manifestations of this intrahepatic persistent jaundice, and therefore he has made that clear. I think that was his idea. Is it right, Dr. Edward?
Yes, sir.
Okay. So now having this clarity, who will come to the possibility that what are the possibilities? First students. Rajat, what is your idea?
So neonatal cholestasis secondary to either biliary atresia or choledochal cyst.
Okay. Why not other possibilities? I will say, why not neonatal hepatitis syndrome?
Sir, I didn't get your question.
Why not, I will say, any infection?
So usually in infection, the child would have been sick looking. For torch infection, so there's no significant antenatal history.
Okay. Can you just, Dr. Rajat, mention that what are the common infections responsible for neonatal cholestasis? Suppose may not be in our case, but we should have the idea. Common infections.
Sir, torch group of infections.
Among the torch, which one? Not all. Common.
Sir, cytomegalovirus and rubella are more common.
Okay, please remember cytomegalovirus is the most common.
Most.
Then rather than rubella presenting, in our medicine anything can happen, but we'll go for the common things. And for that it is cytomegalo, then toxoplasmosis, even hepatitis B, even parvovirus B19. These are the common, and even some other bacterial infection also. Suppose one baby was hospitalized in my NICU for the sepsis. On workup, blood culture, we got the E. coli. And patient had neonatal cholestasis.
Galactosemia.
Galactosemia. So, some metabolic disorders are having the tendency for some sepsis. That also we can keep in mind. How the commonly galactosemia will present? Anybody? Common presentation.
So usually they present with neonatal seizures or intolerance for the breastfeed.
Hypoglycemia.
Hypoglycemia.
Right. Anything else?
And urine reducing substances should be positive.
That can be with your vitamin C also, if you are giving the multivitamin, which may not be very specific. What I mean to say. Clinically, how the patient presents, clinical presentation. One you said is right, hypoglycemia, jaundice.
Lethargy.
Anything else?
Lethargy, seizures.
Okay. On examination, what you will get?
Hepatomegaly.
Let me tell you one of the patients which I came across, I think almost 20 years back. Very young mother, 20 years and 2025. From very, I will say, deprived family, particularly from the education and even economically. Hardly she has never gone to the school. Child was referred to me from the Himmatnagar for persistent jaundice. Child was having both enlarged liver and spleen. We were thinking initially, as usual, torch infection. We asked for these serological tests for the torch. And during that time, we were really more, but I will say, dependent. Nowadays, we don't give much importance to the serological test. On 4th or 5th day, I remember that my pediatrician told me that the torch infection is negative. I said, still it looks like infection. Continue the antibiotics and let us see. And I was talking in Gujarati. So mother came to know. And mother asked me that, sir, is there anything in the eyes? Mother showed me the cataract. And then I told her that maybe the congenital, since birth, I was talking in Gujarati, and very easily we can miss. Even here also you showed me the cataract. But mother was very firm, and therefore I was thinking for rubella during that time, that rubella is likely, although this titer is negative, we can repeat it. But mother told me again firmly that, sir, it is since last 15 days only. I said it can be missed even since birth, but she was very firm. And therefore I told my pediatrician that mother showed us the cataract. Now she is telling that it is not congenital, it is acquired. So think for the acquired cataract with the hepatosplenomegaly and jaundice. Just I was returning from the round and it came to my mind that, oh, we should go for the galactosemia. When for the galactose 1-phosphate iridotyl transferase enzyme, turned out to be the galactosemia. Treated with the lactose free, and as usual, child was recovering. So what I mean to say here, listen to the parents. listen to the mother because she is constantly observing. And here probably mother help us a lot. So I think these are the things just you can keep in mind. Okay. Anything else now? I will have to keep in mind regarding timing also. Dr. Dipen, I think directly I will come to you. You can guide us that what are the various possibilities in these patients, how we should consider.
Regarding now it is time to evaluate the baby by investigations. Sir.
Yeah.
So which are the commonest possibilities in our Indian population with regard to direct jaundice? If epidemiology we have, do you have any data, Dr. Edward, information available?
Most common cause would be biliary atresia, sir.
Right. Okay. Followed by? Followed by any other one, idiopathic neonatal hepatitis, cholestasis. Because when you say it is idiopathic neonatal hepatitis,
sir, initially when the cause is not known, you call it idiopathic. Later, it could have a metabolic or some other cause can be there. Later could be found, but initially when no cause is found.
So previously when there was no information available, especially genetic testing, liver biopsy samples, at those days, idiopathic neonatal hepatitis of unknown cause was considered as a diagnosis of possibility. Now we don't use it much frequently. But anyway, if you have investigated in detail, ruling out all the causes, then at the end, if you don't have anything, then you can label it as idiopathic neonatal hepatitis. So second is unknown origin. Third one would be infective possibilities. So like already we have discussed in detail, TORCH especially, but herpes simplex would be very much.
Yeah.
Yes, so it would be, baby would be very much sick, as we already discussed sickness with cholestasis. So it would appear very early, not late. But cytomegalovirus already we have discussed. Dr. Prajapati sir has already mentioned. So cytomegalovirus should be kept in mind always, even if there are other causes available. So because there are possibility that overlying causes may be there when cytomegalovirus is concerned. So have we investigations like sonography findings we have?
Yes, sir. Can I share the?
I think, Edward, before that, we would like to ask Dr. Amar that what are these other surgical conditions which we should keep in mind? Dr. Amar, please.
Well, the main two surgical conditions that should be kept in mind would be for any conjugated hyperbilirubinemia would be choledochal cyst and biliary atresia. The important fact to note for children with biliary atresia is that these are generally healthy and thriving children, at least till the first 3 months of life. As compared to neonatal hepatitis or any other medical problem where the child would be sick, there would be failure to thrive, etc. So in general, biliary atresia babies are generally well-growing babies and thriving till the age of 3 months. When after the age of 3 months, when the liver gradually starts to deteriorate, that is when the child starts to develop anemia, ascites, failure to thrive, and then the child goes downhill. But otherwise, these are both, I mean, even in choledochal cysts, both, I mean, these are all healthy babies.
Yeah. So I think in these patients, probably then surgical conditions are less likely. Am I right?
Yes.
Because baby is sick, failure to thrive, so many points are there. Okay. So still, you know that our medicine is not so simple. Sometimes even it may turn out to be in some other way. But
Yeah,
I think these are our general thoughts which we can keep in mind. Okay, I think, Edward, now we have the time limit also. You can share the investigations which you have performed, and then again we'll discuss the investigations.
Sir, coming to the investigations done in this child, the complete blood count at admission showed a hemoglobin of 11.6 with a total count of 20,000. Differential counts of 60% neutrophils, 33% lymphocytes, 4% monocytes, and 1% basophils. And platelets were also adequate, 2.28 lakhs. Now coming to the liver function test, total serum bilirubin was 7.4, direct fraction of 5.9, transaminases SGOT was 95, SGPT was 68, ALP was 366, serum albumin was normal 3.5, total proteins were 7.1, and GGT gamma glutamyl transferase was raised at 1289. Now coming to the renal functions were urea and creatinine were normal. Electrolyte, sodium was 132, potassium was 5, chloride was 102, and calcium was 9.4. The coagulation profile, PTNR APTT was also normal for the baby. Blood and urine cultures which were sent at admission have turned to, out to be sterile. Then we had done a USG, abdominal USG for the child, where the liver was found to be enlarged 9 centimeters with altered echo texture. The gallbladder was small sized with non-contracting, thickened echogenic wall of the right portal vein, which may represent the triangular cord sign, was seen. And the final impression on the USG abdomen was features which were suggestive of biliary atresia. Then a liver biopsy was also done, for which the reports are awaited, and we had done a HIDA scan also, for which the images are also available, which was showing non-excretion, sir. So these are the investigations which we have performed for the baby.
Okay, can you stop sharing?
Yes, sir.
I think, Dr. Deepa, I have the question for you. Dr. Deepa, are you there? The question is, in the newborn I'm talking, from the bilirubin estimation, how will you decide that it is the direct type? Is there any criteria? I think when the significant direct indirect fraction, it becomes easy. But when probably they are borderline, we have to interpret it properly. Is there any criteria how you can interpret that? Yes, this is the direct type of bilirubin. Any point? Anybody want? Or Dr. Deepa?
Sir, less than if total.
Edward. For you, the question will come.
Direct bilirubin of more than 2 or more than 20% of total bilirubin. If the direct fraction is that high, then it is direct bilirubin.
Anyway, Dr. Suman Prabhu answered, and he has helped you.
Deepa was answering. Sorry.
Okay. Anyway, I think this is very important that when the fraction is low, you have to go into very precisely for the interpretation. When less than 5 total, bilirubin direct fraction should be more than 1. Beyond that, it is 20% of the total for proper interpretation. I think we have the 2 questions now. We have the very short time, but we'll try to utilize it properly. Number 1, Dr. Deepa, direct question to you. How much importance should be given to the HIDA scan and all other points for deciding this obstruction, or I would say neonatal cholestasis? What is the status of all these tests?
HIDA scan has a role when baby passing a colic stool. So if stool is pigmented and cholestasis is there, then there are possibility that there are other causes.
So my question is,
yes.
Question is, for the diagnosis point of view, how much importance should be given? Suppose HIDA scan does not show the excretion or compromised excretion, should I consider directly biliary atresia?
No, so that is a limitation of HIDA scan.
Yeah.
So if it is excretory, then it will rule out biliary atresia. But when it is non-excretory, then there are other causes also, which we have to think like intrahepatic causes also of cholestasis, which may not be picked up, and that's why biliary atresia should not be labeled straight away as a cause based on HIDA scan. So other findings should be considered, like ultrasonography findings should be there with us. And some blood tests also will help us in differentiating.
To rule it out. I think, Dr. Amar, direct question to you, because being surgeon, I'm sure that you must be very meticulous regarding the interpretation of HIDA scan in even the liver biopsy to lever it. I think one point very rightly Dr. Deepan mentioned, please all the students should remember that suppose if it shows the excretion, then rule it out the obstruction. For that it is good. That means negative predictive value is good. But does not suppose it shows the compromise or no excretion, not necessarily it is only biliary atresia. Other conditions can also behave like this. And I think for that let even liver biopsy also. So Dr. Amar, can you make these points clear?
Sir, to be very honest with you, I mean, I do not believe in doing a HIDA scan for determination of, for confirmation of biliary atresia, because we all know that the positive and the negative predictive values are very less. So we not of late, but for the past 20 years, we have been doing what is called laparoscopic cholangiography, in which you put in a 3 millimeter instruments and you visualize the gallbladder. The biliary tree is visualized. You put in contrast through the gallbladder with a needle, and the entire biliary tree is delineated. So that is, at that time also you can take a proper liver biopsy, because for a liver biopsy to be validated properly, it should contain at least 5 to 7 portal tracks for the histopathologist to exactly identify a proper specimen and label it as biliary atresia, because sometimes the biopsies are also completely non-suggestive, but that is mainly because not of the inexpertise of the histopathologist, but the inadequacy of the liver biopsy that has been taken. So by doing a laparoscopy, you can easily identify the proper biliary tract and also take a proper liver biopsy.
Very good.
So that is the advantage of a laparoscopic cholangiography.
Absolutely. I think Dr. Amar has conveyed a very good message, and all of us should remember, I think the past, we were just following the liver biopsy. During that time, nothing was available to us. And
Sir,
from
I
the
just
liver...
shared the screen. I mean, can
yes,
you
yes, no problem.
See, this
and
is
nowadays, I think
just for the postgraduates to see. I mean, this is what a liver per operative cholangiogram looks like. I mean, see, this is the gallbladder. This is the cystic duct. This is the right and the left hepatic duct. This is the common hepatic duct. This is the CBD, and the contrast is seen going in the duodenum. This was the needle, and these are the laparoscopic ports. And this is what it looks like at laparoscopy. So the liver can also be nicely seen.
Yes. I think he shared the good pictures, and this is very important. Nowadays, even HIDA scan is not, people are giving the much importance from the diagnosis point of view. Okay, it is one of the modality, but not much reliable. Even liver biopsy also, very rightly, because you know that ultimately it's a bile canalically problem. Drainage is not proper. Is it really the not proper canalization of the structures, or really following the inflammation, they are blocked? That is very difficult to differentiate on the liver biopsy also. And therefore, nowadays, I think what Amar said, most of the surgeons do prefer for confirmation, because you know, confirmation is very important to go for the next step for the management. And earliest we want the management. So I think from this point of view, we can, of course, for the initial screening test, we can use all these modalities, but don't rely upon much for the interpretation for the diagnosis. Am I right, Dr. Amar?
Yes, sir, that is perfect. And with the advancement of laparoscopy, you can save a laparotomy and a percutaneous, laparotomy and cholangiography. So if the child does not have biliary atresia, at the end of the day, I mean, the story ends there and then, and the child can be safely managed medically without having to stay in the hospital as compared to a laparotomy and doing a per operative cholangiography.
Absolutely. Edward, anything else, further investigations have you performed, or this is end of the investigation?
Sir, as of now, these are the investigations we have done. So, patient is planned for surgery this Monday, sir.
Okay. So I think now surgery point of view, Dr. Amar, can you take some points? Suppose if it is biliary atresia, then what I will say surgery, or what are even the other modalities available to us, because patient is going to ask us, and nowadays we'll have to answer them.
Yes, sir. So surgery for biliary atresia is a classic Kasai's portoenterostomy, which is done. I mean, and what we do in that is we dissect the entire fibrotic biliary tree up to the portal patch. And I mean, and then we anastomose a segment of the jejunum to that area, hoping that the biliary canaliculi will open, and then they will eventually create a formal tract and anastomose with the mucosa of the jejunum. Now, this is a standard surgery and it has been done for years together. Now, if this surgery is done meticulously, I mean, even if this surgery is done meticulously, it is not that the results are going to be 100%. I mean, we can divide this into aspects of 30, 30, and 30. For example, if you do 100 cases, 30 of them are going to be jaundice free. 30 of them are going to stay with a bilirubin hovering around maybe 2 or 3 or 5, and then eventually they'll require liver transplant at the age of anywhere between 2 to 15 years. And the remaining 30% are not going to do well even with Kasai's portoenterostomy, and they may end up having an early liver transplant. So this is what the things are. And again, the timing of the surgery is also important. I mean, the preferable window that we get for surgery in order to ensure good results is that if the surgery is done before 60 days, then the outcome is supposed to be relatively good.
What is at present the exact time recommended for the liver transplant in these patients?
I mean, I think, sir, the liver transplant, it all varies from the surgeons to surgeons who are doing liver transplants. But I think they require a minimum weight of 10 to 15 kg, I guess, in order for the child to qualify for a liver transplant.
So I think these are the points. And nowadays, all of us are aware that liver transplantation is not away from us. Many centers are doing, even having the good results. So I think as a clinician, we should be aware of it, that what facilities are available in our own country at different centers, and we should know the details to guide the patient, that what are the exact indication, at what time we should submit or consult this center, what are the expenses and other facilities. So I think this is also very important that the practitioners and students of this country, we should be aware of it. Of course, I think further workup or follow-up may be useful to us to know these. And I think now we have to end over here. Before that, any question from any students or any comments from the faculties? Anybody? I think students should come with lots of the questions. And unless you have the questions, probably we cannot learn. For learning, we have to put the questions to the exam, I will say teachers. I am many times in the lighter way, I am talking to my students that you should come with such preparation that teachers should be afraid of you. Take the round. And because you must have read so much, even with the advances, and nowadays we should know. I think for the students, I don't remember the exact year, but our Society of Hepatology and Nutrition and Gastroenterology in our own country, Dr. Yacha and his group even and others, they prepared the guidelines for this even the neonatal cholestasis. I think few years back, I don't remember exactly the date. Please refer it. And they have prepared it with a reference to our country even, as Dr. Dipen was asking, that what is the epidemiology of our country? What are the most common causes or so? So I think that also we should keep in mind. We have to end over one patient I remember that long back, as Dr. Amar was talking regarding the cholangiography. During that time, there was no laparoscopy. It was operative cholangiography surgeons were doing. One older child, it was not neonate, about 1.5 to 2 years old child, presented with a fluctuating jaundice. It was direct type and fluctuating. I remember that in one of the faculties even told in the finding that dark yellow sclera. Next day I found that hardly the jaundice is there after a few days. I said, yes, jaundice is there, but very mild, it's not dark. And then after a few days again, even I found that, oh, and bilirubin was very significant. Enzymes point of view, hepatic enzymes point of view, not much involvement. And Dr. Amar, I know that Madam A.B. Desai, she insisted that you go for the operative cholangiography. Dr. Bhattacharya was there. He took the patient. He was reluctant, but Madam insisted. And on operation, we got plenty of the lymph nodes.
Oh, okay.
And lymph nodes were obstructing, and on cutting and histopatho, they were tuberculous lymph node. So, even obstructions can be different. Even fluctuating jaundice is known with the choledochal cyst also. They can also come with this fluctuating jaundice. So I think as a clinician, we are learning so many other things beyond even books and other things. Anyway, we'll have to end over here because already beyond 8, we are there. Let me appreciate Dr. Edward. I think and even your mentor, Dr. Suman Prabhu, you have selected the very good case for the discussion. I think definitely very good case. And even Edward, you prepared very nicely.
Thank you,
You
sir.
came with the full preparations. That's good. And my request to all other students that remain present, even whatever the discussion is going on. Keep your video on, continue to even ask the questions or to speak something, whatever you are interpreting. And that's I would say best method of learning. And of course, our experts, Dr. Dipen, he put, I will say, the comments very appropriate with his further advancements and other aspects. And of course, the presence of Surgeon Dr. Amar Shah, I know him since many years, very competent, not only from the surgery point of view, but I will say even the clinical interpretation point of view. And he made even the very good points for us, learning for students and for all of us. And of course, all other students, we should not forget our IAP Gujarat State Branch President and Secretary for providing this platform. So we'll end over here. Thank you very much. Thanks to all and good night. Next Saturday, again at 6 o'clock, we'll be there with some new case, and I'm sure it must be with the same excitement. Thank you very much. Dr. Sneha, over to you.
Thank you so much, sir. Thank you so much, everyone. The presentation was very much informative. It was a nice session. So thank you all for your comprehensive talk. Thank you all and have a nice day. Good night.
Good
Sir, can
night.
we?
Thank you.
Good night, sir. Can we end this session here?
Yes, yes. Thank you.
Thank you.
Thank you. Thanks a lot.